Welcome to the deep dive. Imagine checking the news tomorrow and seeing that Medicare just slashed the price of GLP-1 weight loss injectables down to like $245 a month.
Wow.
Right. And patient copays are capped at just $50. Through this new direct-to-consumer platform, TrumpArcs, these wildly popular drugs just became financially accessible to millions of beneficiaries overnight.
That is honestly a seismic shift for the healthcare market, but the immediate impact is going to hit smaller, independent primary care clinics the absolute hardest.
Yeah, and that is exactly our mission today. We want to equip you, the physician owner of an SMB clinic, to handle this massive wave of demand without, drowning in administrative burdens or triggering a devastating billing audit.
Because over the last couple of years, patients who couldn't get coverage were bypassing traditional doctors altogether. They were just paying out of pocket at cash-only telehealth startups to get their prescriptions.
But at $50 a pop, they aren't going to stick with those cash-pay startups.
No.
They're going to bring those Medicare benefits straight back to their local primary care doctor.
Right.
Which means your waiting room is going to be flooded.
Exactly.
And, I guess it's like a retail store suddenly announcing a 90% off doorbuster sale. Which sounds like a financial win, but are clinics actually staffed to handle this? Won't the registers basically just break?
Oh, they absolutely will if your systems aren't ready. The administrative bottleneck is exactly where clinics get married. You can have a waiting room full of eager patients, but if your coding and documentation aren't flawless, you're just generating a ton of unpaid work.
Right, because Medicare and private payers are heavily scrutinizing these specific claims. So let's get into the weeds on that coding, starting with the new CDC ICD-10 E-codes.
Yeah, the E-codes.
We're talking about E66.811 through 813. We've always used Z-codes to report a patient's BMI. So why do we suddenly need to pair a Z-code with an E-code just to get paid?
Well, think of it like trying to get through customs. The Z code is your passport, right? It just gives the raw data, the exact BMI number. But the payer also wants a visa, and that's the E code.
Oh, okay, so the E code adds the context.
Exactly. It proves the clinical severity of that BMI by classifying the obesity into class 1, 2, or 3. Without both the raw data and the clinical context working together, the payer simply rejects the claim right at the border.
Got it. Okay, so raw data plus clinical context.
Yeah.
But then we have to add in Medicare's G0447 code for face-to-face behavioral counseling.
Yeah.
And the frequency limits on this are just brutal.
They really are. You bill it weekly for the first month, and then it drops to every other week.
Wait, and to keep doing it monthly for the rest of the year, doesn't the patient have to lose exactly 3 kilograms by month 6?
Yep. 3 kilograms.
If I'm running a small practice, I'm pulling my hair out. I'm trained to treat patients, not act like a forensic accountant tracking 3-kilogram milestones just to justify a 30-minute counseling session.
I know. The frustration on the ground is totally justified. But payers are looking at the sheer volume and the cost of GLP-1s, and they are demanding quantifiable proof of clinical efficacy.
So if a patient isn't hitting that 3-kilogram mark,
the payer's algorithm just assumes the medication and counseling combo isn't working, and they cut off the funding.
Geez. So even if you thread the needle on the coding, you still have to clear the prior authorization hurdle.
Oh, absolutely.
Looking at medical mutuals criteria, for example, they want a documented BMI of 30 or higher, or 27, with 2 specific comorbidities, plus proof of a 3-month behavioral modification trial, before they even consider covering the drug.
Yeah, and that 3-month trial is where clinical documentation basically saves or sinks a practice. You have to prove you did the groundwork. This is where the 5As framework becomes your best defense.
Right. Assess, advise, agree, assist, and arrange. But give me a practical example. How do you actually put that in a chart without it looking like generic boilerplate text?
Well, instead of just writing discussed diet, you systematically document the interaction. You assess their current eating habits, you advise on a specific caloric deficit, you agree on a realistic weight loss goal for the month.
Okay, that makes sense.
Right. And then you assist by providing nutritional pamphlets, and finally you arrange a 2-week follow-up.
And package that all up.
Exactly. When you package that clinical narrative inside a letter of medical necessity, you explicitly connect the patient's history to the payer's rigid demands. You leave them zero room to claim inadequate documentation.
Incredible. But all of this intense scrutiny makes me wonder about the off-label side of things. If a patient doesn't quite meet that 30 BMI threshold, but really wants the medication, the temptation to prescribe off-label is huge. Is that just wandering into a minefield for an independent clinic?
It is arguably the fastest way to trigger a devastating audit right now.
Really? That fast?
Oh, yeah. Because these drugs are massive budget items, insurers are actively hunting for off-label prescribing. Submitting misleading documentation to bypass those BMI requirements doesn't just result in a denied claim.
It's way worse.
It opens the door to insurance fraud allegations, really aggressive recoupments, and potentially losing your medical license.
Wow. So the takeaway for you managing a clinic right now is crystal clear. Treat the administrative plumbing with the exact same level of care as your clinical diagnoses.
Absolutely.
Master the paired E codes and Z codes, build the 5 A's into your charting muscle memory, and do not play games with off-label prior authorizations.
Preparing those systems now is really the only way to survive the patient wave that's coming.
Right. But it does leave you wondering about the long game here. The Congressional Budget Office is already predicting that anti-obesity medications will eventually yield massive savings from improved overall health. Fewer heart attacks, less joint surgery.
The downstream effects are huge.
Exactly. So if GLP-1s eventually become as routinely prescribed as statins, will insurers finally drop these intense PA requirements? Or is this bureaucratic maze just a permanent tax on your clinic's time? Something to think about as you prep the clinic for tomorrow.